Greetings, I'm Jeff Carter with Seattle City Club. I go by he, him. Welcome to this virtual Civic boot camp program on addressing racism in community-based health programs. Just so you know, Seattle City Club is a small nonprofit with a big mission to strengthen our community through conversations on critical issues like this one and encourage civic engagement. And with that, I'd like to welcome our moderator, Christin Ayers, executive producer of Facing Race at King 5, who will kick off the conversation today. Welcome, Christin.
Thank you so much, Jeff, and welcome to everyone who decided to join us today. We have a big group. As Jeff said, my name is Christin Ayers. I'm the executive producer of Facing Race, which is our race and equity reporting unit at King 5. That's a position that has been newly created within the past year and some change. And normally in journalism, when we talk about issues, important issues like this, race and healthcare, we talk about these things in sound bites. So I'm really excited to have the opportunity to talk about it in more than sound bites, to have an actual conversation about, this important topic with the panelists who we have present here today. So without any further ado, I will allow our panelists to introduce themselves. Let's go ahead and get started. And let's start with Jiquanda Nelson.
Hi, everyone. Happy to be here today. I'm Jiquanda Nelson, and I'm here as president of the African American Health Board. Thank you for this conversation in this space.
Okay, next up, AyeNay Abye.
Thank you for having me. My name is AyeNay Abye. I'm the CEO of Tubman Health.
Okay, we also have Sophia Aragon.
Hello, everyone. I'm Sophia Aragon. I'm the Executive Director of the Washington Center for Nursing, and I am a registered nurse. Thank you for having me.
Absolutely. You guys would do great in the news world because those were some brief introductions. I was ready to sit back and kick my heels up and wait to hear all of your long resumes. But, your work does sort of speak for itself, and we will get the opportunity to jump in and really get to know you as we move forward today as well. I want to just hop right into some of the foundational questions in this conversation. And I'll start out with some questions that I'd really love for all of you to feel free to jump in and answer. Let's start with just the general impact of racism on public health at the community level. What is that impact, especially when it comes to our region and Washington state overall? AyeNay, I'm going to ask you to start out answering that question, the impact of racism on public health at the community, region, and state level.
Thank you. As I was sharing, I'm the Tubman Center for Health and Freedom, and we address both the clinical as well as the systemic issues. And so I want to focus more on the systemic issues to your question. Each one of us on this call, our health outcome is impacted almost up to 90% by the conditions we are in. So where you live, where you work, who your communal networks are, all of those things matter on impacting our health. And so in our field, we call it social determinants of health. And that has such a big role. Most of the time, there becomes a narrow conversation around our health, that it's about an individual's behavior or our genetics. Because I am Ethiopian and African American, I'm more likely to have X, Y, or Z. But that is not the case. The case is based on the conditions in which I live in this county, in this city, that determines my health outcome. So there's a critical connection between kind of the public sector, what's going on in society, and the individual, which is racism. Right. Which is racism.
Saving the best part for last in that answer there. Boom. Dropping the mic already. Yeah. Let's check in with Jiquanda. I have the same question for you.
Yeah, I mean, what more can we add on to what AyeNay has already said, right? Around the conditions around where we really center ourselves as an organization is around looking at how is community impacted by centering our work through community partnerships, right? Oftentimes people within institutions or organizations who have a certain level of power and resources tend to go off and make decisions without consulting with community or the people who are closely impacted by the organization. So that's where we really ground our work as a African American Health Board, to number one, make sure community voice is the loudest voice in the room. Community leaders are seen as subject matter experts in community and help shaping strategy, resources, allocations of where we kind of focus our efforts and our resources, and making sure that we're compensating community for doing that. Because oftentimes we fall into the trap of putting the responsibility of racist systems or organizations not being held accountable on the very same people who are impacted. So that's really where we center our work, is community voices. Because without having community voice, we continue to have the same problems, we continue to have the same issues, because we're not getting close to the people who are impacted the most by racist institutions.
I love what AyeNay has already brought up, and also Jiquanda. So 90% of our health status depends on what is around us in our environment. Absolutely true. So what's implied in that, and what's also true, is that for healthcare, so we're talking about health, yet clinical care really counts for 10% of what your outcomes are. So we really need to put into perspective what kind of impact healthcare providers can have when it comes to promoting health. And I'm really happy that Jiquanda talked about centering communities, because that, for the Center for Nursing, has really been the most effective way to develop the strategies to improve health and create actually a better workforce that's more responsive to the needs of communities. And I don't need to mention COVID-19, and we also need to keep that fresh in our minds and the lessons there, right? That our Hispanic community were affected 3 times the rate of white population in terms of illness and death. With African American population, it was twice the amount. And then the Asian population was affected in a different way because of the way that virus was communicated. There was lots of discrimination that resulted from that. But I think I will add to the question in terms of what does it mean for racism of public health at the community level. I agree that what it means is we keep hitting our heads up against the same problems. So we have unneeded suffering among those who are seeking care. And I'll say, from a provider standpoint, it can also lead to burnout, because clearly what we are doing isn't moving the solutions forward. And we as providers, and I think I personally have experienced this, feel like I'm not really contributing to the solution and providing care. And that's a problem, especially in COVID, when we're having significant turnover and exodus of nursing in the profession because of the pandemic. For regional, I think what that means is that we need to consider the makeup of our region to craft the best strategies. What are your demographics? Okay, so the Puget Sound region is going to have different needs than Eastern Washington, for example, because there's not only racial and ethnic different demographics, but there also are differences in socioeconomics as well as environment. And as for the state, they really have an opportunity to look at the policy level to see what can they do to address racism in public health, but also conversely, because we know that there are historic reasons as to why racism exists, to really look at what are current policies and what are we doing today that perpetuate racism in healthcare and therefore poor health outcomes.
Thank you so much for adding that context in. I want to move on to, we often hear this phrase, culturally responsive or culturally appropriate healthcare. And I would love for each of our panels here to kind of define what that is and talk about why it is important. AyeNay, let's start with you.
For Tubman Health, for us, our name is not just an adornment. Harriet Tubman was a nurse in the Union Army. She fought for freedom and gave clinical care. And so for us, we look to kind of a patient-centered medical home as a model to utilize. We can no longer, as Sophia was saying, the system doesn't work. We can no longer keep sending our relatives to a system that isn't designed for them. And so for us, it's important to establish a new model of care. this model exists. And so I think for us, it's important to implement it, but also to Sophia's other point around the policy work, where it's a complex system. And we have to put as much or even more so emphasis on healthy system interventions. It's not just about healthy individuals, but our systems are not healthy. And that is what's making us sick. So I think behavior change within our systems is about policy and advocacy and systems design and complex systems theory, and to be able to deconstruct that. Also within public administration, if you look at the impacts of law, 80% that impacts communities based on race don't even mention race in the law. And so there are ways in which marginalization occurs that within the ways things are implemented within the public sector, within governance, within management. So it goes from interpersonal racism that you might experience in a clinical setting, at work, waiting for the bus, whatever it is, that you also experience structural racism that's baked into the ways our laws are constructed, as well as the way we manage. We fund things all the time with Tubman Health. People ask us, how can we invest more into this kind of work? Because everyone agrees with it. Everybody agrees the system's not working. It's not just investing into this work. It's also, where are the counter investments? Where is the money now? It's actually not a scarcity model. There's money out there. How is it being used? So if you look at our county, investing within public health, it means looking at the entire $12 billion King County budget. It's not just how are we funding this public health department. Health isn't all policies.
Some powerful statements there and some powerful context there as we look at where the dollars are actually going, just like you said, and looking at a wider scale of what that means. Sophia, you talked about policy. How does that play into your definition of what culturally responsive or appropriate healthcare is?
Well, policy in terms of policies and laws, I think the most relevant is how we pay for things. And I think we can recognize that we don't pay for wellness, but we pay for the bits and pieces and activities and everyone, the equipment, the medication to treat health. So I think that's just a really important thing to bring up, because what's the incentive then? The incentive is to treat, yet like what I said previously, how we treat may not necessarily impact the outcome. So when I was thinking of this question, and it's typically a standard question when you ask a practitioner about what is culturally competent care, and we have our textbook definition, I think for me the take-home lesson is that it's not a one-size-fits-all. And I think that's where we get in trouble. So when I was a nurse at Community Health, and by the way, I failed to say that was the best job I ever had, but didn't even realize it until looking back, probably 25 years later, that, if you're working with a population that's either doesn't have English as a first language, they may not even have a written language from where they have come from. You can't just give them a pamphlet and send them home. It's like we literally have to reorient. How do we do our outreach and education and treatment? And it's not on our 9-to-5 schedule. We've had, and again, with immigrant populations, for example, that are in service industries, the essential workers, as we have come to call them during COVID, we need to work around their hours. And we did have much better outcomes that way. So I think the big lesson in terms of what is culturally competent care is to be okay with saying it's not, healthcare delivery is not a one-size-fits-all, and that's part of the problem.
That does really crystallize it. Thank you so much. Jiquanda, let's hear your answer as well.
Yeah, I think along the same lines, one of the biggest barriers and challenges that we see is that those who are administering care, those who are making decisions about care, typically don't reflect the makeup of the communities in which they are serving, right? And so for us, again, it's not only bringing community voice, but also advocating that, organizations need to put a priority on opportunities for leaders who reflect the communities in which they serve. We have been huge advocates of community engagement workers, whether it's through public health or within institutions, to hire people and not depend solely on organizations who are volunteer organizations, again, who are doing work that should be the responsibility of institutions, right? So for us, it's about how do we advocate for making sure that those who are making decisions about strategy, dollars, and resources reflect the actual community in which people are being serviced. And once you start to do that, number one, you'll see it reflected again in where monies or resources are allocated. You'll also see the different unique dynamics or kind of nuances, right, that comes with specific communities and specific needs, because that voice is at the decision-making table. And so again, we just really ground our work in making sure that community is reflected throughout all of the processes of systems. I will also say that we are huge advocates of creating new systems, because deconstructing is, number one, it takes a long time, and number two, it isn't always, always successful and gets to the root cause of care. But we also believe that our current systems that are in place need to work. And so there's a level of accountability that needs to happen there.
Thank you so much. I think each of you have talked about, just to some degree already, some of the challenges that we're faced, that some of these systems and institutions face when they are trying to address racism. So I guess the question is, how do you work within that system and within the larger healthcare system to address racism and try to enact change? And I think that kind of dovetails off of what someone was asking here in the chat about, they specifically asked AyeNay to elaborate a bit more on the new model that exists, but is not being implemented, as you mentioned. So let's have you address that, AyeNay.
Yes, so at Tubman Health, we are implementing a patient-centered medical home model, and that's a clinical model. We're merging that with the gold standard of public health practice, which is communities know best. So for us, our goal is to open up a patient-centered medical home by 2025 in South King County or in South Seattle. And with that, we are currently in our design phase. And Sophia was pointing to this, really how important it is for community to design what the interactions look like, what the services are, what is it that they need, from the built environment to the soft arrangements. And so for us, we are being really intentional about having community design what this patient-centered medical home looks like, feels like, what the engagements look like, what services we offer, the hours in which we are open. So you can, if you'd like to learn more, you can just Google patient-centered medical home. There's a bunch of literature out there on it. And so I would say that's the kind of nexus we are in, is that with the gold standard of public health practice, which is communities know best. And so we are giving ourselves ample time for that to be created.
Communities know best. It sounds simple, but it's amazing to see how often that is overlooked. Sophia, I would love to hear your answer to that as well. How do you work within the healthcare system to try to, address racism and try to change things?
Mm-hmm. Well, nursing is the largest healthcare workforce in the state of Washington, particularly registered nurses, and it's the same for the nation. And when you have a really large population or group like that, there's just inherent diversity in that group. And also we have lots of nursing organizations that all have a really important part in how the nursing community provides care. So lots of complexity, yet also a lot of opportunity. So for the Center for Nursing, we're a nursing workforce center, and the standard that we strive for, and there's over 30 other nursing workforce centers around the country, is really have really good data about, so what does a nursing workforce actually look like? And so the center has been really focused on providing that picture. And the point of it is not to just collect data, but actually inform policy and workforce development. And I think that because the WCN has had a really strong diversity and equity initiative, that we wanted to go beyond collecting what is sort of the baseline of demographics, right? So like the 5 federal categories that everyone's familiar with that you answer in the census. What we wanted to do was follow what the state did. And there's a really good model by OSPI where they disaggregate the data. And I'll say as an example, from the Asian community standpoint, and there's been lots of advocacy around this, is that they felt it was really important that the 27 recognized groups under Asian are recognized, and doing so, we understand sort of the unique contribution. So back to the nursing workforce, we collect data on the demographics of nursing. Overall, we can see that we lag in diversity compared to the Washington state population. Registered nursing is a little better in terms of moving to align with Washington state demographics. But then there are other areas of nursing, such as nurse practitioners, where we need to increase diversity in those ranks. And also another important group are nurse educators. So when we talk about having a workforce that is representative of your population, it's really important to us to use this data to say, you know, how do we encourage more diversity in these ranks that are, by their position, are leadership ranks? And these are the nurses that can really call the shots and create the direction in which our workforce is going to go. So if you're a nurse educator, I mean, you're the only type of nurse that can duplicate nurses, right? You're creating them, you're teaching them, you are the one to deliver that practice skill of what is bias, what is racism, how do you deal with it in practice? And when you're a nurse leader, you are in charge of the resources of that organization. Are this their training that you're going to provide so that people are aware of disparities that are affecting your organization and your patients? How are you allocating the resources so that patients get more equitable care? How are you hiring? What does your retention look like? Are you constantly striving so that your workforce and your organization are reflective of the community you serve? So we hope to influence by data, and we do take on certain programs. Like, for example, we got together with multicultural nursing organizations to develop a program where it's a couple of pieces. One is to encourage diverse nurses to be nurse educators. And then we're also developing another program where we provide mentorship to diverse nurse educators so that we can increase their retention in their ranks. So those are some examples of programs that we do that are flow out of the data that we have.
And just a quick follow-up question from the chat there. Are there any specific names, companies, or training modules that you'd be willing to name check, Sophia, that come to mind for you?
Training modules?
Yeah, when you or companies that you recommend who are working on these sorts of making these sorts of changes from within.
Yeah, actually, not off the top of my head, but if I can get back to you, I would be happy to think back about, because I have met a few resources, but I just can't think of them right now, but would be happy to provide that.
No worries at all. And you can feel free to enter them into the chat at any time as well.
Sure.
Jiquanda, I would love to get your answer to that question as well about addressing this racism within the larger healthcare system.
Yeah, so we have a really unique position, I would say, because we are made up of a group of, volunteer base of professionals who actually work within the healthcare institutions here locally and abroad, and also community leaders, folks from education, public health, mental health and well-being. And so we really do rely on the strength of the subject matter expertise from whatever that is for folks. We even have some folks who are community healers. And so we bring that within our work. And so what it looks like in terms of the organizations, number one, we have folks who are within the systems who know kind of how things work, who knows the greatest gaps, and are able to connect that to the community relationships that we have built, again, through community voice, through community-based organizations, et cetera. So I would say that is a core component of our work, is really being this convener, really being able to connect all of those pieces together. I would say the other piece of our work, which is really important in how it impacts systems or institutions from a broader systemic perspective, we use a lot of our energy and resources and capacity around advocacy at the state level around different bills. We've done some update to policies. We've partnered with, we are one of now, I think, 16 ethnic health boards across the coalition for healthcare. And so for us, we believe that, again, we need the systems that we're in to work. And the way you do that is through greater accountability, through bills, through policy, et cetera. So that's where we focused our efforts.
I want to ask how, each of the panelists here, how your lived experience has informed your work. And we're talking race, gender, background, all of the above. And Jiquanda, I'll go ahead and check back in with you first.
Yeah. I think, there's so many different ways that I can position this, but I think for me, just like in early childhood, living in a community that was predominantly white, and I was in a gifted program. I use air quotes because I have perspectives around what we call gifted and what that looks like in education. But I just very early on, I realized that number one, I was treated differently because at that time, I didn't understand, I didn't have the language because I was the only. And also just different levels of access around privilege that became really real, right? And so when we think about what the greatest barriers are to healthcare, it's around privilege and it's around racism, right? Because folks who get to create the systems get to say, you get to have this type of care, or you don't have access to this type of care, or we're not even going to consider what type of care you need because we want to make sure that those who we want to have access have that, right? And so for me, really like going to my core of knowing what it feels like to not have the same access and privilege of people, even looking at my friends in my community who didn't have the same education system and they were in a classroom right next door to me, right? And so for me, I always go back to that experience of number one, how do we bring voices of people who are impacted the most? And how do we address the system that creates this division or these kind of levels of who is deserving and who isn't deserving? And that's what really, really, really grounds me in this work.
AyeNay, I want to ask you the same question about how your lived experience has informed your work.
Yeah, that's a great question. For me, I mean, I can take it all the way back, but one of my ancestors, Reverend James Preston Poindexter, is an abolitionist and was very much involved in Reconstruction. And so then going all the way to my grandmother was a podiatrist. She had a clinic in the back of our house in Pasadena, California. And the school children, she would go to the school and our neighbors would come to our house. My mother has a PhD in education, international education. We are degree central. We are public administration central. We've done it all. For me, it's hard to swallow that my children, their quality of life is less than my ancestors. It's hard for me to swallow that I focus so much on raising them and they are targeted by the police using my tax dollars. It's very hard for me to swallow that I champion education, and then I send them to a white institution that tries to erase who they are as they're trying to attain their degrees. So for me, it is very much about the future and about future generations. And that it's not for my children to carry. It's, again, it's for all of us. It takes a village. And that's the perspective that I look at, and what Jiquanda was saying around just partnerships in the ecosystem. Black people did not create racism. We've been marginalized by it. We've been categorized by it. And so for us, it's about participating in partnership in the ecosystem. Because again, our health is in the hands of our community. Who keeps us safe? We keep us safe. We learned that through COVID. Who keeps us well at a communal level? We keep us well. And so for me, that is how I approach this work, and has influenced everything that I do in my leadership, in my organization, and in my partnerships.
Thank you so much. And thank you for going all the way back. That was fascinating. Sophia, same question to you. Your lived experience, how does it inform your work?
Yeah, well, so I immigrated here from the Philippines at the age of 3 with both my parents. They were both in healthcare. I'll say that healthcare was perceived as the ticket to the United States, where there is opportunity. And even I think I look around at my various cousins now, is that it's still true. They may not just be nurses and doctors and pharmacists, but they are lots of different facets of healthcare. And my mother actually discouraged me from being a nurse. She said, you're going to work really hard and you won't be respected. So no, I don't want you to do that. I want you to do something else. But looking around, and understanding the challenges and struggles they had as a family, it was more important for me to see that nursing was a way of stability, and it was a way of putting food on the table no matter what. I look around at my nursing aunties in my family, and no matter what the economic situation was, they were always employed. And they always put food on the table. They always made sure that the mortgage was paid. And to me, that was incredibly important. And I think I've had lots of discussions too around, this experience of assimilation. And it's not just a Filipino thing. I think there's lots of other cultures and Asian cultures that do that. This sort of, and actually it's very much kind of unsaid, but modeled, that you just kind of keep your head down and get to work, right? That's what you just need to do. But I think growing up as a professional, I think that this has really been a journey for me, because I think keeping your head down and working worked for a while, and I could have just kind of kept doing that. But it is real in being able to reach out and make connections with people like AyeNay and Jiquanda, who I just met today, and even yourself, Christin, and being in these spaces where you learn about this common experience and what is that. And there's that opportunity that there's just greater public appreciation, there's public outrage, there's a public demand that, we could do things better for diverse peoples, I think is a really great opportunity. So I'll just tell you that, growing up just as an individual, I don't think I was very reflective about it, but when you're in this professional space where there is that opportunity now to solve problems and related to racism and be amongst leaders who care about this, that's been quite a journey, and it continuously evolves, which is part of the challenge, both good and bad.
Sophia, I want to, since you're talking about your own experience as a nurse and growing up, I think it's an opportunity to sort of talk about nurses in general being on the front lines of healthcare during the pandemic. And I'm curious to know, what unique role do you think that nurses play in addressing racism, and how your organization helps to support them in that work?
Well, Washington is one of the few states. I think there's California, study, and then there is an ongoing nationwide study that looked at the impact of COVID-19 on the nursing workforce. And again, as a leader in the community and as the organization that sponsors that kind of research, I could direct the parameters. So for example, I could have just kind of thrown, when we create the survey, we said we make sure we have an equity lens to these questions and the information you're looking for, because the question you're trying to answer is very important. And one of them was, what's the impact from an equity lens on nursing? And so one of the things I could have done, and this is pretty standard practice, is you cast the net to all the nurses in the state, over 100,000 people, and let's see who answers. And if we get a certain percentage, that's great. And by research standards, there's pros and cons to how many people can answer. But what we've done, and we continue to do this at the center because it's so effective, is that we have relationships with the Multicultural Nurses Organization. So Mary Mahoney is the Mary Mahoney Professional Nurses Organization is for Black African American nurses, Pacific Northwest Chinese Nurses Association, Filipino nurses, the Samoan nurses, and we keep trying to grow this network. And so we've discovered that from either recruiting from programs or getting feedback in the survey, we get the representation, meaning demographically. Like, so here's a simple example. If we know that 30% of our population is diverse, we kind of want to see that in our survey respondents. When we cast the wide net or even just post it on Facebook or something, we get nowhere near those numbers. But if we start with these multicultural organizations, we get those numbers. So we've stopped. We used to go do the wide net and say, oh gosh, this isn't representative. Let's go to the multicultural nurses. And we've just learned we're just going to go straight to them and make sure that they have first chance to answer these questions and give us information. And so we've been successful that way. That's how we've been able to get on back to the COVID-19 situation. Also where we see inequities is in framing that study is we made sure we got the voices of those practitioners in the areas that were hit the hardest, but the least resource. Public health, okay, 1% of registered nurses work in public health. Community health, 5% work there. And we all hear about the impact to schools, only 2.5% of nurses work there. Long-term care, 10%, which has really been decimated and just been really saying, you know what? Yes, most nurses are in hospitals, but let's make sure we got those voices. And I think we've been able to coordinate, influence the national study. And one thing I will share that because of COVID, there's been layoffs, right? So we've had elective surgeries were on a halt because of safety concerns. And of course, we had to be really mindful of resources because we could have easily overwhelmed hospitals. But in watching, say, employment rates, it was interesting to see, and this is what the national study is showing, is that nurses of color are slower to be re-employed than white nurses. And it's just really interesting. It's like, that just, just put that out there. We don't know why, and the study will keep going and look at that. But it's really good to see that working in collaboration with partners that we can highlight impacts like that.
Thank you so much, Sophia. Jiquanda, I want to ask you, we've talked a bit about how the African American Health Board has tried to address racism in healthcare and work to address it. Can you talk about how that work is done supporting local institutions to try and address racism in healthcare and from a policy perspective as well? What have you had success with passing and what more is needed?
Yeah, thank you for that. So I would say the biggest way that we've been able to help institutions is again through our network of again, just a broad range of diverse professionals who have committed their lives to doing this work and who are deeply connected and rooted in community, right? Like that has just been our thing. If you want to know what's happening with community from voices of community and people who can connect it to work that's happening around racial equity, racial justice and access, you can come to the African American Health Board, right? So I would say that first and foremost. From a policy perspective, I can and I can give you an example. So one of the first things that we did with when the pandemic hit and we started again seeing all of the things that many of us already knew around the barriers and access issues to healthcare for Black, Indigenous people of color, right? We had come together with our broader coalition of health boards, and we created very specific demands, which were solutions to helping get Black, Indigenous people of color access to not only healthcare, but of course, COVID-specific care. And so the 3 areas that we outlined specifically to the Washington State Department of Health and to public health of Seattle and King County was supporting actionable race, ethnicity, language, and language data collection, because without having the right level of data, right, and transparency around the data, it is very hard to impact care. It is very hard to impact care and hold institutions accountable. The second thing was to establish anti-racist healthcare protocols, right? Whether that's around training, whether that's around Black, Indigenous people of color nurses not getting opportunities for employment, making sure that our voices were at the table, making sure that there was accountability with the organization, and we outlined very specific, tangible actions that these organizations could implement. And then the third area was investing resources and building relationships. So again, investing resources in community, right? So one of the things that I can tell you from just an organizational perspective as a community organization, one of our biggest barriers is not having the capacity to do the work that is necessary to do that. We are a benefit, right, to local institutions. We bring, again, that voice to the table, that level of partnership across the state to the table, that level of subject matter expertise of professionals. However, many of us are working full-time jobs. We have families, we have community engagement. We want to read, we want to be able to exercise and hydrate and drink water, all of the things that we have to do to be humans first, with coupling that with now being asked to come to focus groups, come, support, et cetera, without compensating people for their time and energy and resources. So we are also we see ourselves as advocates to say, we are happy to support and partner with you, but you need to compensate the people who are actually helping you with work that you should be doing as an institution providing care. So I just want to wrap that up. Specific bills that we've been able to support, one was around, it was House Bill 1272, and it was around health systems transparency. We were an active voice in that. We also spoke to House Bill 1076, which was around Worker Protection Act, around labor, again, fair treatment of healthcare workers, specifically Black, Indigenous people of color, and then also Senate Bill 5229, which was around equity and continuing education for healthcare workers. Because again, if you think about the pipeline and bringing diversity and bringing, again, Black, Indigenous people of color into levels of care across all levels, as well as administration, we have to invest in education. We have to invest in making sure that we're breaking down those barriers, like financial access, educational access, that prevents that from happening. So those are some of the ones that we have advocated for and been successful in terms of engagement. One of the things that we're doing now as an organization is a specific Black community health needs assessment, which we are partnering also with Tubman around to see where we need to place our care from our own, leaders and healthcare providers and institutions, because again, we've all kind of been compiled and put together as a group when there are very specific needs. And so really excited about the work that we're doing at a policy level. And we just continue again to address our work from a very systemic perspective and strategy.
Yes.
Thank you so much. Important for us to both hear about the, issues that are present, but also the successes as well. So thank you so much for that. AyeNay, did you want to add to that?
Yes, definitely. Our partnership with African American Health Board is really important in terms of looking at the Puget Sound region, but also the state. We know what is going on in the Rainier Valley. What's going on in South King County is also going on in other parts of the state. And so we're also looking forward to building out that partnership and funding it. Also to what Sophia was pointing to, I also feel like it was how I introduced ourselves. It's like that pause in which we all know what the data is saying. And then we're like, why do Black nurses, or they're not hired at the same rate as white nurses? And we all do that pause. And I think every single one of us have that in our institutions, and we know what it is. And that is actually why Tubman Health got formed. We opened our organization 4 years ahead of schedule. We are actually planning to start this in 2025. But when the pandemic hit, again, institutional behaviors, we're very aware of institutional behaviors and what occurs in the workforce, what's going on. So we launched Tubman Health early. And so for us, the organization might only be 1.5 years old, but all of us have decades of experience in this work and in many facets of the institutions. And it was the Black nurses who were with us on day one. In Rainier Beach, we were at the Safeway handing out masks, having conversations with community members, just saying, this is real. We know you're getting all kinds of mixed messages, but that's how Tubman Health was founded. We were all volunteer founded. And we knew this was the time where people really understand the intersection of health and freedom, and how racism is so pervasive in all of our institutions. And so for us, having, a Washington Center for Nursing, having African American Health Board, all of us in these conversations, and here on this panel, I think we have what it takes as a region. It's about that honesty and not doing that pause around racism. It's let's get to the root. It's the root that is plagued. We can add innovation on top of it, but it's the root of it that we need to address. And so we like to call ourselves a health justice organization. Let's get to the root of health inequity. And so I just really appreciate this conversation, Jiquanda, Sophia. I'm learning a lot and taking notes, but I just wanted to jump back in there on that. Thank you.
Health justice organization, that is so appropriate. Makes so much sense. AyeNay, I want to just check in with you about, you spoke a bit about this new model with the Tubman Center and how it will address racism and health justice. Can you also talk about how it will address some of the interconnected systems of oppression? So when we're talking about race, citizenship, disability, gender, class, how will those all be addressed?
By having those communities design what it is that we're offering. And so for us, using an organizing model coupled with it, to where if you think about like community health workers, using organizing to have communities engage and say what is it that they need. We just recently concluded a study called Well Us, in partnership with 12 other organizations, and it's called Wellness Equity by Lifting Up Local Underreported Solutions. We have a lot of data out there on what systems say about our communities, but what is it that our communities are saying? And so within Well Us, some preliminary data is that people have solutions. The thing that they've pointed to is that insurance doesn't cover the solutions that they have for their healthcare needs. And so our next step to our study is looking at how insurance is a driver of health inequity. People have solutions, they know what they want, they know what they need. They don't do it because of their insurance. And so that's the next step to our Well Us study. And so for us in this design phase, it's really looking at research, policy, community voice and choice, and what services work for them. And that we will put together in a patient-centered medical home. And so one of the, I'd say, conditions that we're also facing is the urgency of the current moment, of not having the best healthcare delivery systems for Black people. We're also getting a lot of requests like, start the clinic today, start the clinic today. And we're like, no, because then we're just going to replicate these existing systems. The whole point of it is to have community design it. And so we're actually just trying to like make a buffer and like push it out and say, no, we need at least 2 years for community to really design what this is, what this looks like. And to what Jiquanda and to what Sophia are saying, it's designing the whole thing. It's how can the workers have health and freedom? How can the patients have health and freedom? How can the budget and operations be healthy and free? And so there are a lot of things for us to design collectively, but I believe our community has the knowledge, our workforce has the knowledge. It's about how do we rearrange this? How do we take those same inputs, arrange them differently for different outcomes? Right now, the current stacking and arrangement keeps yielding the same outcomes. And so we're like, okay, how do we start with new arrangements that centers community?
It's exciting to hear about that approach and that it keeps coming back to community. At the end of the day, it's about the long game there and not just getting it out there as much as it's needed now, right? I want us to, we have just a few minutes here before we jump into our small groups to discuss things further. But I want to ask the panel, as we look at, the successes and the failures of the system overall, I want to know what key things still need to change to address racial disparities in healthcare, and also what gives you hope that that sort of change is possible. Feel free to jump in.
I was going to say, I can jump in on this one. And I'm also very biased because I work within a healthcare system, doing work of diversity, equity, and inclusion, as well as workforce development. We have to get people who reflect the community into decision-making spaces, right? Not as figureheads, not as, folks for us to put on our websites to say, hey, but look, we have this so-and-so, right? We have a Black doctor, we have right? We need people who reflect the communities in which we serve, closest to the issues of the people in the communities that we serve, making decisions about how we approach, design, resource, and support healthcare, period. What brings me hope is the future generation, because they don't believe in just adopting some systems because they're there. I think they're going to dismantle all of this. And so folks like me who are a little bit on the older side, right, who have done a lot of the work, is really focusing on mentorship and learning and connection and imparting resources and wisdom into the future generation. And then of course, organizations like Tubman Health, who are like, we're doing it and we're doing it right, really excites me and gives me hope.
Well, I think that it's really this shift in thinking of what is that system, right, that is holding us back, that is perpetuating racism in the system. And to be honest with you, it was really hard to get to that systems thinking point. And thinking back of the many opportunities for education or training, it's because these systems are invisible. It's habitual. Think of like the hamster wheel that we're on every day. It's like that wheel. It's like, why are you on there? Why do you keep going? It's not going anywhere. But then you don't know, because that's the only thing that's there. So for me, that's been a major learning. And I think for leaders, that they really need to examine what that is. And I think too that on an organizational level, there's always this balance of self-reflection. So we, as an organization, want to see this change outside of us, outside in the greater nursing world. But what does our organization look like? So we're a nonprofit. We have a board of directors. Is our board of directors reflective? Are we intentionally recruiting, or do we just have people who come on board because they're willing? And that's not necessarily bad, But when you're out there talking about, let's be representative, it's like, are you doing that for your own organization? It's that walk the talk in motion. And what gives me hope, I think, is that the national attention to racism, that I could see slowly the community is being more comfortable talking about it and not avoidant. It's the pause that AyeNay talks about. It's okay to point that out. It's like, why, to think about, oh gosh, somebody raised a question about it and we hear crickets. We don't hear anything, and just not ignore that or say, okay, nobody wants to talk about that. But there's something underneath that. And I think just slowly people willing to talk about it or just ask questions with curiosity and not be so afraid of it. So I think I can see that slowly happening, and also that funding is coming behind it. I think, the Robert Wood Johnson Future of Nursing Report, the vision for 2030 frames the nursing workforce we need, and the outcome is diversity and more equitable system. That is our whole goal. How do we get there? And it's not just, item 9 on a list of 10 things that we need to do by 2030. So I think that gives me hope. And when you see people put resources behind this effort, that's a good thing and much needed.
I agree. I think in the region, we all know we're all suffering because of racism. It's a public health crisis. Again, it's happening in our community and everybody's impacted by it. In a classroom, when you have a Black teacher, educational data shows all students do better. All students do better in the classroom. When you have a Black doctor, Black pediatrician, infant mortality goes away, right? So everyone does better with diverse workforce. So I think to what Sophia's pointing to, what Jiquanda's talking about, I think people see it. It's about the investments in it, and are we going together? Because again, we center public health practice here. Community knows best, and we are in community together. And those marginalized within the community know best of actually how these things operate. So when we're talking about marginalization, that is a byproduct or direct thing from racism. Marginalization comes directly from that. And so when you reach people at the margins and center the margins, we will raise the tide for all ships. And so and then we'll solve this conundrum where we can have people of color raising our babies, driving you to work, cooking your food, doing all of these being your nurse, doing all these very intimate things, but yet we're not trusted to steer the direction in which we need for our own systems. It's like this conundrum we have. It's like, what? We're good to drive you to school. We're good to take care of your baby, clean your house. But we can't say what we need and get what we need for our own health. And so one of the first programs Tubman Health launched was called Frontline Wellness. And it was to address racism in the body. And this program is not based on your income. It's really based on, if you're experiencing racism, sign up with Tubman Health and we will get you 10 free acupuncture sessions to address racism in the body. And so for us, it's really being attuned to these contradictions and resourcing what it is that we're hearing from community.
That sounds revolutionary. I would love to sign up for some acupuncture myself after my racist experiences at work.
Yes, please come tubmanhealth.org and Frontline Wellness. You can sign up through the contact us link. So please. You're welcome.
So needed.
You're welcome.
So needed in so many communities. Thank you so much for that. We are not done yet. I'm going to turn it back over to Jeff just quickly here.
I'd like to, in our last few minutes, I'd like to invite each panelist and Christin to share one final thought, closing thought for all of us today. How about starting with AyeNay?
My closing thought, my breakout group is amazing. And so I really just want to appreciate everyone in the breakout group who was sharing and making the connections. And we got there quickly. Again, it goes to the point earlier is that we have the answers. So let's try it. It's about praxis. It's about theory and practice. And we have to practice the alternative in which we want to move forward.
Thank you. Sophia, your final thoughts.
Sure. I think we got into a really good discussion on just identifying some things in the system that we can do better. And a person really brought up really good end of life issues. And from my perspective, being in the clinical community, I don't think that is something that is explored very well in any type of clinical education, whether it's nursing or medicine or any other type of role. And so we don't quite get to, if we don't build comfort and expertise about giving compassionate care at that time of your life, how are you ever going to get to the question of what's culturally appropriate at end of life? So I thought it was just a really good example of some barriers that we have in our system that are perpetuating, and we really need to think about how we could do better to get to the question of how to be more culturally appropriate.
Thanks, Sophia. Jiquanda, your final thoughts.
Yes. Pay the people who can bring you what you need, right? When you are partnering, thank you so much, Seattle City Club. We appreciate that. Oftentimes we, come under the guise of partnership and collaboration, but then the responsibility still falls on the people who are most impacted. Pay your people, whether it's through a grant, whether it's through budgeting in your organization, whatever it is, pay the people because it is going to benefit you absolutely. But we also want to be equitable and hold ourselves accountable to even how we move forward in partnership. So those are my last words. Pay the people that are helping you.
Thank you so much. Christin, final thoughts.
Absolutely. I just want to thank everyone on this panel for taking the time to talk to everyone here. I feel like I've learned so much in a very short amount of time. I was joking that I feel like I got a PhD in like an hour in some of this stuff. As I said earlier, my work has been in telling stories in sound bites. It is so refreshing to actually hear deep analysis, context, statistics, and also just the philosophy on the importance of community in building, some of these systems or breaking out of some of these systems as well. So thank you so much for your generosity with your time and your knowledge, talking to all of us about this.
Thank you so much, Christin. If everyone wouldn't mind, please unmute and give our speakers a round of applause. That would be wonderful. On behalf of CityClub, a special thank you to our speakers, Jiquanda, AyeNay, Sophia, and our moderator, Christin. Please join us for Year in Review on December 14th, where we'll cover the big issues and top headlines of 2021 with Congresswoman Pramila Jayapal, Gary Kaplan, CEO of Virginia Mason and Franciscan Health, Brady Walkinshaw, CEO of GRIST, and Anila Afzali, Executive Director of American Muslim Empowerment Network. It will be a great conversation. So also a big thank you to our Civic Bootcamp sponsor, Alaska Airlines, for their generous support. And please take a few minutes to fill out the evaluation form. Your feedback really helps us in creating better programs. So thank you very much. Take care and stay safe.